Hello everyone. I'd like to thank the AIOS for the opportunity to speak on extreme cases of iris loss. These are my financial disclosures with no relevance to my talk today. Repair of an iris defect, if small or moderate, can be done by suturing either by direct closure or pupil cerclage. However, a large iris defect will need to be replaced with iris prosthesis, and this may be made of either PMMA or silicone. Today, my talk will focus on artificial iris. So this is a 48-year-old lady with a bottle cap injury to her left eye, rendering her 6/120 in vision with a traumatic mydriasis, and also as we allowed the trauma to settle, we saw vitreous in the anterior chamber. She developed an intumescent lens that was subluxated with complete zonular loss nasally. So at surgery, you can see this lens is intumescent with vitreous in the anterior chamber, which has been stained by the iris pigment and also some blood from the vitreous cavity. And you can see the lens wobbling. And the first thing to do is to remove this vitreous in the anterior chamber. We cannot phaco or aspirate the lens without doing so. Then we stain under viscoelastic with the trypan blue. And you can see that I had attempted a femtosecond laser, which did not cut through because I had not increased the energy for the femtosecond laser. And you can see now the rhexis is a little more difficult because first it's intumescent, but also because the zonules are weak. And after creating an adequate size capsulotomy, we are then supporting the equator of this lens bag with a capsule hook and then expanding the equator of the capsular bag in the plane just under the anterior capsule that has been cleaved by viscoelastic. Because the lens is soft, we aspirate after supporting with 4 hooks, and then before we move our instruments, we put in viscoelastic. And you can see the vitreous cavity is all stained with vision blue. After inserting the toric lens and adjusting the alignment, we remove the viscoelastic from under the lens and then refill the anterior chamber, and we mark 1.75 mm posterior to the limbus and create the Hoffman pocket at least half scleral thickness deep. Now we create the suture snare with 26 gauge needle threaded with a Gore-Tex 7O, which is called CV8. We use the suture snare, come under the iris remnant, extend a loop of suture to lasso the end of the suture loaded onto the capsular tension segment to the scleral fixation point, and we repeat this maneuver for the other end of the suture. So we then retrieve the sutures from the Hoffman pocket and adjust the position of the capsular tension segment into the bag, and we repeat this for a diametrically opposite position so that we have a good support of this lens complex. So we are now retrieving the suture ends with this extended loop of suture which lassos the end of the suture to the fixation point at the sclera. Now once we have done that, we retrieve again the sutures from the Hoffman pocket, and we are going to ensure that we have no vitreous left in the anterior chamber before we fix this. So we stain again with, this time, 50% diluted triamcinolone acetonide and ensure that there is no vitreous that is prolapsing around the equator at this point in time. Fill up the anterior chamber with dispersive viscoelastic, and then we adjust the tension of the sutures with the 211 knot to center the IOL within the eye. We don't look at the rhexis, but we look at the IOL for centration. And once we have done this, we're then going to reconstruct the iris with an artificial iris from Human Optics, which we have folded. This is without fiber, as we can implant it into the capsule bag. It's been trephined to 9.5 mm in diameter, and we insert this into the stained capsular bag so you can see that it's going into the bag and not into the sulcus. We grip the pupil there with non-toothed forceps and then insert it and unfold it into the bag. Once we've done that, we remove all the viscoelastic, and then that's the end of our case. So you can see here that this patient post-operatively had a good visual outcome and a beautifully reconstructed pupil, and you can see the remnant iris following the trauma. So this is another patient who had post-surgery aphakia and anorrhea following extracapsular cataract extraction, whereby she lost half her iris, and you can see that the better eye was really having a severely brunescent cataract, and that's why she underwent extratapsal tetride extraction rather than vacoemulsification. So this patient at the time of surgery, we have marked diametrically opposite points and also at 45 degrees in between. Now we're going to ensure that there's no vitreous, so we stain with triamcinolone acetonide 50% and we cut with a 23 gauge cutter from the trocar cannula inserted 3.5 mm posterior limbus. Now we're doing a Yamane fixation technique and we have to inject this leading haptic right into the 27 gauge needle, and in this case this is a Zicity Lucia 202, which has got haptics made of PVDF so that we do not destroy the haptics as we manipulate it, and going 2 mm posterior to the limbus, 2 mm away from the limbus. From this point we then insert the 27 gauge needle and thread the trailing haptic into the bevel and retrieve the sutures and apply cautery to create this flange that is not too large. And we can see, because this pupil is widely open, that the lens is in reasonable position, although it's not perfect. We ensure that the flanges are buried into the sclera. Then we thread a 27 gauge needle with the Gore-Tex 7O. This time we're using artificial iris with fiber from Human Optics. We refine to a size white to white diameter plus 1 round down to 0.5. The next closest 0.5, and then we mark the 45 degree points after creating a peripheral iridectomy. So once we've done that, again we mark 1 mm posterior to the limbus to fixate the artificial iris with fiber, and we create 4 Hoffman pockets that are 90 degrees one to another, and then we fold the artificial iris, and you see that sutures come in front of the iris. And once we have folded it into 3, we enlarge the incision to 3 mm and insert this with the Kelman forceps, holding on to the iris as we unfurl it in front of the intraocular lens has been intrascleral haptic fixated, and ensure that the iris goes behind the residual iris. And now we're using the suture snare, which you can see nicely because there's no iris there. We extend the loop of suture, thread the end of the suture that we want to bring to the scleral fixation point. There's one point. The other suture is now going to be threaded through by this extended lasso. We pull it, and then we can then retrieve the sutures from the Hoffman pocket, and we're going to do this for all 4 scleral fixation points. When there's residual iris, we go under the iris like you would do with a capsular tension ring. We extend the suture loop to lasso the end of the suture sutured to the artificial iris at that point, and then we retrieve both ends, and you can see bit by bit we are going to fixate this, really very anchoring it very strongly to the sclera. You can do 2-point fixation opposite the points where the haptics are fixated, but you can also do this 4 points, and I prefer to do this generally. And you can see now we adjust tension to center the pupil to the eye, and then we tie and finalize the knots with the 2-on-1 knot and slip it back into the Hoffman pocket. This is the outcome, and you can see this patient in fact achieved good vision with a beautiful pupil, 3.36 mm, and she's 6'9", unaided. So in conclusion, artificial iris can be inserted into the capsular bag, that's the one without fiber, or sutured to the sclera, that's the one with fiber, and these come from Human Optics in Germany. You need to pre-order some of these if you want it to be to match the fellow eye if it is a colored iris. This minimizes glare, provides a good cosmetic and functional result. So extreme iris loss can greatly benefit from artificial iris implantation. Thank you very much for your attention.